Bismillahirrahmanirrahim. This photograph is a part of CT scan. Uh, the CT scan series of the abdomen with oral contrast administered. The patient is a 63-year-old man who had an episode of acute epigastric pain 2 months before. The X-rays were taken. He has presented with persisting upper abdominal pain. Which one of the following would best explain the current radiological finding? So this is the CT, which we can see now. So here we have to make a diagnosis from this short history and this CT scan. So options are hydrated cyst, gastrointestinal stromal tumor, splenic cyst, peptic ulcer, gastric outlet obstruction, peripancreatic pseudocyst. The CT section is taken through the abdomen at about the level of L1, viewed from below the right abdominal structure to the left of the illustration and vice versa. The upper pole of the left kidney is visible, as is the lower pole of the spleen. A large section of the right lobe of the liver can be seen, and contrast is present in loops of small bowel. Fecal material can be seen in the colon, visible at the hepatic and splenic flexure, immediately anterior and partially obliterating the anterior border of the pancreas is a 5 centimeter cystic swelling. The contents are homogeneous. Anterior to the cyst, omentum can be seen. This would be an unusual site for an hydrated cyst. Another option was hydrated cyst in the abdominal cavity. Most of these lesions are found within the liver. In addition, anhydrated cyst usually has a well-defined lining and is often septate and multilocular due to the presence of daughter cyst. The lesion could be a gastrointestinal tumor, but the radiological density is more in keeping with fluid content. The contents of obstructed stomach tend to be heterogeneous due to the mixture of the food and fluid within the obstructed organ. Given its position, homogeneous nature, and the past history of pain consistent with an episode of acute pancreatitis, the swelling is most likely to be a peripancreatic pseudocyst. So this is the peripancreatic pseudocyst on CT scan. The next question is 25-year-old man falls on his outstretched right arm with a subsequent severe shoulder pain and limited movement, especially when attempting to elevate his arm over the head. His appearance is illustrated. Which one of the following is the most likely diagnosis? Fracture of the surgical neck of the humerus, rupture of the shoulder rotator cuff tendon, dislocated glenohumeral joint, rupture of the long head of the biceps tendon, dislocated acromioclavicular joint. So the correct answer is the dislocated glenohumeral joint. The normal shoulder contour in front view has the caul of the overlying deltoid formation, forming a smooth convex bulge from the bony lateral margin of acromion over the humeral head, then dipping back to insert into the deltoid tubercle in the upper third of arm. Dislocation of the humeral head from a fall on the hand invariably occurs through the weakest part of the capsule below and anteriorly. The normal convexity of the deltoid is thus changed to a flattened contour, so that in most obvious case a line run vertically from acromion would run unimpeded to the lateral epicondyle without normal bulge of the shoulder. The displaced head of the humerus can usually be felt anteriorly under the anterior axillary fold. The patient cannot raise the arm above the head, and all shoulder movements are painful and inhibited. And the fracture of the surgical neck of the humerus are most likely to be due to a fall on the shoulder, and the shoulder deformity is not the displacement seen with dislocation, but of a local bruising and tenderness. Dislocated acromioclavicular joint gives a typical step deformity at the top of the shoulder due to the rupture of the retaining coracoclavicular ligaments. Rupture of long head of biceps tendon often occurs spontaneously in elderly patients in a tendon which is the site of the long-standing previous attrition. Symptoms are usually minor with minimal discomfort associated with an obvious bunch of prominence of the long head muscles belly unflexing the elbow. So this is the uh, long head of biceps tendon rupture. Here you can see the bulge, the long head of biceps rupture tendon. A 15-year-old girl present with itchy red eyes and redness of the skin of the upper and lower lids as illustrated here. Itchy red eyes and redness of the skin. Which one of the following is the most likely diagnosis? Conjunctivitis, hordeolum, chalazion, local drug reaction, glaucoma. This is a very clear question. So from this rash, we can say that this is most likely is a local drug reaction, because conjunctivitis will not present with this rash type of. Uh, you can see the rashes are on the on face, and hordeolum, chalazion, glaucoma will not be present like this. So this is the most likely is a local drug reaction. So the conjunctivitis is inflammation of the conjunctiva, and most commonly conjunctivitis is a bilateral. The common causes are infection, viral, or more commonly bacterial, and allergies. Stye is a or hordeolum is a small, painful, pus-filled abscess in an eyelash follicle caused by bacterial infection. It may involve the eyelash and may be confused with the chalazion. The latter does not usually occur at the lid margin. A stye is treated by pulling out the infected lash. Chalazion is a lump caused by blockage of the small glands, which is meibomian glands, which produce an oily secretion that coats the lid margin and directs the tears to the drainage system at the medial end of the eyelid. So here we can see the picture of the chalazion and the stye. So this is a very clear difference how we can diagnose this chalazion and the hordeolum. How can we can differentiate? So here the answer is the local drug reaction.